All right, are you able to see my screen?
Yeah, I see it.
All right, I am changing my controls, or I will take control and you can just tell me when you want the next slide.
Okay, perfect. If you can advance 2 slides, that would be perfect. Yes, thank you. All right, well, sorry for the rough start. I was touching things I shouldn't have been touching. So let me start off with a short introduction. My background is that I'm a physiotherapist. I'm a hand therapist as well. And in 2010, I started off using ultrasound on an old black and white basic machine that we jokingly refer to as the kitty litter. You can see it in the center of the screen. So it was a very basic machine back then. And 2 years later, I got a job opportunity to work as a teacher at the Dutch National Training Center for Ultrasound, NTE. And I've been there since. So nowadays I get the luxury to scan on high-end systems. So you could say I'm a bit spoiled now. In our facility, we train MSK ultrasound and we train pelvic floor ultrasound for pelvic floor therapists. And we mainly teach physios, but we also see an increasing demand from orthopedic surgeons, sports medicine physicians, podiatrists, and physician assistants that are picking up MSK ultrasound. And like Madeline said, in my time at NTE, I have trained maybe over 800 physios in MSK ultrasound. And in these years, you could say I've seen the good, the bad, and unfortunately also the ugly. So there's good points and there's bad points, and both will be in the presentation for the viewers. It is my opinion, though, that ultrasound can be a very useful tool in the hands of a physiotherapist, but only if they're properly trained and they know how to integrate it into clinical practice. So in this webinar, I will discuss the pros and cons and show you some clinical cases. So if you could advance the slide. Yep, thank you. So first, let's start off with a little bit of background on physiotherapy in the Netherlands to get a good idea of how this works, because in every European country this is different. Physios diagnose using the International Classification of Function, the ICF, whereas medical doctors use the International Classification of Disease, the ICD. Since 2006, though, there is direct access for patients for physiotherapy. So this means that there's no necessity to see a doctor first for referral. They can go straight to the physiotherapists to be treated for their complaints and to get a diagnosis. Though physios are not trained for using the ICD, these boundaries are starting to become less clear, because if you decide to treat a patient, then you need to work with some form of diagnosis. So this is a peculiar paradox and sometimes difficult to comprehend for people outside of the Netherlands. The Dutch Association for Physiotherapy is currently debating if by 2025 all physiotherapists in the Netherlands should have a Master of Science degree, which would increase the level of clinical reasoning. And this will help physios to critically appraise scientific literature. And perhaps in the future, we could even start using the ICD classification. With all the above mentioned developments, there is a debate about setting up an extended scope rule like in the UK. So after getting a Master of Science degree, physios could do university degrees in specific areas that could allow them to fulfill roles outside of the scope of regular physiotherapy practice. So for these things, you have to think like doing injections, prescribing medication, and even direct referral for medical imaging in the hospital. This extended scope role fits the current developments where expensive hospital care is more and more carried over to primary care. So if you can go to the next slide. Thank you. So what's the situation in the Netherlands with MSK ultrasound? Well, the first physio started with this back in the 90s, but the more widespread applications started at around 2010. There are no official numbers on the amount of physiotherapy clinics using ultrasound, but we estimate this number to be around 10 to 15%. Physios use ultrasound to help in the differential diagnosis, obviously, but it's also used to train specific deep muscles using visual feedback for the patients as an alternative to EMG. And in the literature, this is usually referred to as RUSI, which is short for rehabilitative ultrasound imaging. And lastly, ultrasound is used to guide the physio for chronic tendinopathy treatments like shockwave therapy and percutaneous electrolysis, which is a minimally invasive technique using a galvanic current through an acupuncture needle. You can see it in the picture on the right. And this technique originates from Spain, but it's gaining popularity in Europe and can give surprising results, especially on pain in the short term for the chronic cases of tendinopathy. So the last couple of years in the lower segment, and for ultrasound, the lower segment would be around 15,000 to 20,000 euros. The price quality ratio has dramatically improved. So the barrier to start scanning is becoming lower and lower, and more clinics are buying a machine. Something to note, which is important, that's in the Netherlands, there's no extra charge for the patient for an ultrasound. So it does not cost the patient anything extra. Usually the scan is done within a regular physiotherapy session, which in the Netherlands is around 30 euros. That would be around $34. So the clinics buying the equipment are not out to use it as a money-making machine, but in general just want to add ultrasound to their daily practice to improve the care that they can give. So all the above is very good news, but for the quality of the sonographers, there is an important issue since there's no official national certification or any law in place to, have any control over the quality. I will delve into this later into the presentation. So now I would like to take you through some of the pros why physios should be using ultrasound in their clinic. Obviously, if a physio is able to make a more accurate diagnosis, the therapy that's then chosen should be more specific to the condition, and this should always result in better outcomes. And by making this more accurate diagnosis, there is less need for sending patients to the hospital for expensive imaging, which makes it also cost effective. And if the patient is sent to the hospital, this should be a more directed and useful referral because there has been already a screening by the physiotherapist. Nowadays, patients really expect high value care. So just diagnosing by the physical examination can sometimes be insufficient to convince the patient, especially with the chronic cases that have already seen another clinician and have not had any result with that clinician. So then they start to get illness beliefs that something is structurally wrong. Sometimes I do decide to scan patients, sometimes just to show that there's no structural change. This can give them a lot of relief, and then they buy into your treatment and become more compliant. The last point is that in physiotherapy clinics, we have more time with the patient than many other clinicians. So this gives us a unique opportunity to do the clinical examination and to scan the same patient. And therefore you can correlate these images with the clinical presentation and you can get a better total overview of the patient. Because what I've noticed is that normally the treating clinician and the sonographer, they see the patient separately. And what happens quite a lot is that a lot of information is lost in translation. So yeah, it's better if the clinician does their own scanning. As for the impact on the patient perspective, you can go to the next slide. Yeah, thank you. As for the impact on the patient perspective on physios using ultrasound, I found this interesting study. And in this study, they did a simple survey with 130 patients that saw a physio in a specialized shoulder clinic. And as a part of the assessment, the physio made the ultrasound image and gave direct feedback of the images to the patient. So in the graphs, you can see that these patients feel they understand their condition better, which is the one on the left. They feel more reassured and they feel better able to manage their problem. All this is, of course, just patient perspective, so it's a very simple study. And the last graph shows the value that the patient gave to the ultrasound scan, which is a really high score. Like I said before, now the patients expect high value care, and just the fact of making a scan can already add value, at least in the perspective of the patient. So now let me take you through some typical cases that a physio might encounter in the clinic. First case, you can see on the left, is a typical patient with a chronic subacromial pain syndrome, the SAPS. The pain is localized within the deltoid area, so it's a bit more distal to the glenohumeral joint. And this is a typical location for the referred pain of a subacromial pain syndrome. The patient's illness belief could be that the problem is located where the pain is, so near the distal deltoid. By just using words, it can be difficult to convince the patient about this referred pain. So you could consider scanning this area and compare the left and right shoulder, showing them that there's no difference in structure. So it's not really a diagnostic scan, it's just to convince the patient that the pain is actually originating from another location than the place where it hurts. And I think I heard a radiologist once, I think it was John Jacobson, and he called this the patient satisfaction scan. And he suggested to always add this scan to your standard shoulder scanning protocol. So the second case would be, let's say, a 67-year-old lady with an acute and very painful shoulder, but without a trauma. The ultrasound scan shows a calcifying bursitis, which is usually a result from spontaneous resorption of a cuff calcification within the bursa. The patient might be very worried because of the extreme pain, but this is actually good news. So the calcium is being resorbed in the bursa and is causing acute bursitis, and this bursitis will then clear up the calcium. The prognosis is that this patient will be completely pain-free within 10 to 14 days. So with the ultrasound image, you can help the patient understand the complaint and that there's no necessity to do an expensive referral to the hospital, and the patient can be managed multidisciplinary together with the GP for the pain. So there's no need to go from primary to secondary care. And then the third case, let's say this is a chronic lateral epicondylalgia, also known as the tennis elbow. The patient has been having a pain for almost over a year now, and he has seen various healthcare professionals. He has done his exercise therapies with physio, but nothing helped. Now he comes to you for help. And after taking his medical history, you pick up on an important cue. The patient says he's worried that the tendon might be torn. So you do your clinical tests, which all point to a regular tennis elbow, but the patient has strong illness beliefs that there is something more serious going on. So you can then decide to add an ultrasound scan, look for anything out of the ordinary, like a loose body or perhaps some capsular involvement. But in the end, it just shows a typical tendinopathy of the common extensor tendon, and you show the patient that there is no tear. Just by showing this, that there is no tear, this can give the patient a lot of relief and can also help him be more compliant to the therapy route that you choose. So it gives a lot of confidence to the patient that the route you choose is adequate. And also, anecdotally, sometimes the pain might drop instantly by 2 to 3 points on the VAS scale just because the patient is less worried. So you might even see the scan as a pain modifying intervention in this case. If we can go to the next slide. So where does medical imaging fit in the clinical reasoning process for a physio? Typically in phase 1, which you can see on the top left, we take the medical history and we do our physical examination. And after this, we should have a good idea about the diagnosis, also taking into account things like the age of the patient and the prevalence of certain diseases or conditions. And in the box below, you can see the probability of the condition on a scale from 0 to 100. Usually after taking the medical history and the physical examination, you should have enough certainty about the diagnosis to start your treatment, which is the green arrow at the bottom right. But in many cases, as a physio, you're left doubting because most clinical tests are not very accurate. So in these cases, ultrasound could increase your certainty significantly, depending on the area. It is important, of course, to know the diagnostic accuracy of ultrasound for the condition that you want to diagnose. So if you don't have an ultrasound machine yourself, if you can click one time. Yeah, this is what usually happens if you don't have an ultrasound machine yourself. You want to have more confidence in your diagnosis, to have more certainty, and you might send off, which is the red arrow, to the hospital for ultrasound imaging or any other imaging. And that's usually a lot more expensive than when it's done in primary care. So this way, if you can go to the next slide. Thank you. So by taking away the ultrasound imaging from the hospital, bringing it to your own private clinic without charging anything extra to the patient, I have to add, there will be less unnecessary referrals to the hospital, and a much more cost-effective system arises. So less referrals to phase 2 and phase 3. And if they are referred, like I said before in the presentation, this should be a more specific referral, so more adequate to sending the patient to the hospital. Okay, so if you can go to the next slide. So to round off, because this was all very theoretical, I'd like to share some interesting cases with you. This is a case of a 30-year-old male CrossFitter. Since about 3 weeks, he is experiencing an inability to do certain exercises involving his right shoulder. He tells me that it is a vague complaint since there's no real pain, but he's reporting a certain loss of control, and he cannot pinpoint the exact location of the problem. So with the physical examination, there is a clear loss of exorotation strength, which might indicate a problem with the infraspinatus muscle or tendon. So to evaluate these structures, I decide to make an ultrasound scan. The cuff tendons in this case have a normal appearance. I don't see any fluid around the biceps tendon on the front, which might indicate an interarticular problem. But when I scan the dorsal glenohumeral joint, I see a circumscribed, anechoic, and non-compressible structure adjacent to the dorsal labrum and lying deep to the infraspinatus muscle. And on the left image, you can see the long axis view of the infraspinatus, and on the right, you see the short axis view. Note in this case that the infraspinatus muscle belly itself has a normal appearance. If you can go to the next slide. Because I also scanned this patient near the supraspinatus, where this is a short axis view you see on the image, short axis view, and you see there the similar circumscribed structure lying deep close to the superior labrum in this case. So when I combine these images with the clinical history, because this looks like a paralabral cyst, you can see it on the right, and you can see that these can compress the suprascapular nerve. So the suprascapular nerve is located very close to the glenohumeral joint, and this is a motor branch innervating the infraspinatus muscle. So the loss of the strength could be an indication that there's a compression in this area. So putting the images and the clinical presentation together, I have about a 90% certainty that this is a nerve entrapment of the suprascapular nerve. I then look at the literature to see what I can do as a physio, but it's pretty clear that there's very little I can do to get this patient better. So this condition falls outside of my scope of practice, and in this case I have to refer him to the general practitioner. Then the next case This is very interesting. These are images of the knee of one of my students that attended a course the other day. She had some history of knee pain, but she wasn't experiencing any at that moment. While scanning her dorsal knee, we can see a Baker cyst originating from the typical location between the medial gastrocnemius and the semimembranosus tendons. She was not aware of this cyst before we scanned her knee. Usually these scans, these cysts tend to stay superficial, just deep to the subcutaneous tissue. But in this case, you see that it travels proximally and deep towards the popliteal artery. As you can see, it is located right next to the artery. She then confirmed that the last couple of months during her running, she was getting strong cramps in the leg after running just a few miles. And if left untreated, this could result in compression of the popliteal artery, as seen in a similar case posted by Kawari et al. You can see that on the right. I referred her to the hospital, and she is now on the waiting list to get an ultrasound-guided aspiration. And for the attentive viewers, there's another interesting finding in this clip. So if you saw it, please share it in the chat. Next case. The next case is a case of a 45-year-old runner. He has chronic dorsal ankle pain and a painful Achilles tendon for over a year. A physiotherapist had diagnosed this as an Achilles tendinopathy combined with a stiff ankle joint and gave exercises aimed at loading the tendon together with some mobilization techniques. The tendinopathy for the patient improved, but he was still left with a stiff ankle. He was referred to me for an ultrasound scan, and the patient also tells me at that time that every now and then the joint is stuck in a certain position for a couple of hours, and then it seems to return to normal. And this is, of course, a very important clinical cue. On the ultrasound image here, you can see the long axis view of the Achilles tendon with a slight tendinosis, but deep to the tendon and in the Kager's fat pad, there are two hyperechoic structures with acoustic shadowing. They are surrounded by fluid and seem to lie within the flexor hallucis longus tendon sheath. Since they lie within the sheath and the flexor hallucis longus sheath has a connection with the dorsal ankle joint capsule, these are probably loose bodies coming from within the joint. As you can see on the image, the two structures can move freely within the sheath and can possibly cause intermittent dorsal ankle impingement. And this seems to fit the clinical picture, and the patient is referred to the general practitioner since exercises or mobilization techniques cannot help to improve the patient's condition. So to conclude this webinar, I would like to discuss the cons, and perhaps this is good material to discuss in the Q&A following this webinar. First off, and by far the most important factor, is the fact that MSK ultrasound is difficult and it's operator dependent. To become a good sonographer, you need lots of experience and you have to put a lot of time and money into training. There is a common pitfall, and that is that people tend to invest in an ultrasound machine, but not in adequate training. And this can have some serious consequences for the quality of care, because the quality of the machine will not make up for the low quality of the sonographer. And I always recommend to get feedback on your scans by an experienced sonographer. This is essential for a proper learning curve. The problem is, though, that a lot of people are unable to find a good mentor. And another thing is that they don't make enough scans per week. Always be aware of serious pathology. A physio is not trained like a medical doctor, and there should be limitations to what you should or should not scan. For instance, lumps and bumps is a no-go for the physio. And your differential diagnosis before the actual scan should lie within the scope of physiotherapy practice. So no scanning of organs, no scanning of skin conditions. And I am saying this because quite often patients do ask you to scan the strangest things. So try not to get tempted to do those. And the last bullet point is a Dutch expression. And the Dutch expression is unknown equals incompetent. So for instance, if you rarely see patients with wrist complaints, don't bother scanning them and focus on the areas that you do see frequently in the clinic. You need to know the whole spectrum of the local anatomy and all possible differential diagnoses before you start putting a probe on this area. This will not lead to a good quality care. So that was it. Thank you for your attention. And if you're watching the recorded version, do not hesitate to send me any questions by email or on social media. And I think it's now time for some Q&A following this webinar. So over to you, Madeline.
Thank you. Thank you very much, Niek, for being here with us today. We did have one guest that came in for the question that you had asked during your presentation, and the guess was chondrocalcinosis in the knee. Is that a correct guess?
Well, I wouldn't know, actually. That's funny, because these kind of things can happen. You see within the cartilage, you see something. If you can go back to the image, perhaps.
I believe it was this image.
No, one more back. Yeah. Yeah, this image. You can see the bony structure of the dorsal cartilage, and within the cartilage you see some hyperechoic structures. And if you see the movie playing, you will see that there's quite a couple of structures within there. So the only thing that I can detect as a physio, because I'm not trained as a medical doctor, is that I can see that there's something there, and I can see it's not how do you say this? It's not arthrosis or osteoarthritis, you call it in English, I think. But I see it's not within the normal scope of what you would expect. So this is just detecting that it's abnormal and then referring on to the hospital. So I referred her actually to a rheumatology department because they're trained in arthropathies, and they will diagnose what it actually is. But it could be chondrocalcinosis, yes. But as I said, I'm not trained to make that diagnosis, and so I won't make the diagnosis.
Well, thank you. And it was a great suggestion from the audience, so thank you.
Yep.
We did have, I know we're close on time, but we did have a great question that came in that I think was really pertinent to your talk today. So I did want to pose it to you. The question is, what does the future of MSK ultrasound and physiotherapy look like in the next 5 to 10 years?
Yeah, that's a good question. If it follows the current developments, it's going really fast. So the machines are becoming better and better and really quickly. And also the handheld machines, which are, you can even connect them to your phone. They're not adequate yet for MSK ultrasound. That's my opinion, at least. But I think they will be within maybe 5 years. So what you get now in a bigger machine, you will be able to get it even on your phone with very high quality. So the availability will be much higher. That will mean that a lot more people will start using it. And I think even medical doctors, you see a picture here of the lady with a stethoscope around the neck. And they even say that ultrasound is a new stethoscope. So the doctor will be walking in with an ultrasound probe around the neck in the future, perhaps. And for physiotherapy, I think it will be the same. So I think in the end, all clinics will have a machine and 1 or 2 trained sonographers to make a diagnosis, I think.
Wonderful, thank you. There are a few other questions that have come in through the queue, and I've notated your names. I will be sure to pose those questions to Niek and submit them to him, and we will be able to email you some questions and answers throughout the next couple of days. But Niek, I do want to thank you so much for being here. We really appreciate your time today. For those of you that are here live, we are going to be providing a recording of this webinar on our POCUS.org website for you to watch again or share with your colleagues. For more POCUS talks, please check out our Focus on POCUS podcasts, our POCUS blogs, and of course, follow us on social media where we post regular POCUS clinical challenges. We do have 2 upcoming webinars, one in March. The POCUS Academy is going to be offering a question and answer session with Jasmine Rocket, and one upcoming in April, it's going to be focused on ultrasound and emergency medical services with Peter Bonadonna. You can register for both of those on our POCUS.org website, and we look forward to having you join us for our next webinar. Thank you all very much for attending, and I look forward to having you join us next month.